Extract 1. Questions 1 to 12.
You hear a doctor talking to a patient called Brian Harris. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. What's your problem?
Well, last year I had a traumatic injury to my left posterior. I got hit from a boat while I was in the water. I immediately rushed to the hospital where I had to undergo surgery. I'm still having an external fixation on the wound for healing fractures in the leg. I had undergone grafting and full-thickness skin grafting close to defects in my posterior thigh. It is almost healed right in the gluteal fold on the left area. In several areas along the graft site and low in the leg, there is several hypergranulation tissue developed.
Is there any bleeding from the wound?
No, doctor.
Okay, what's your age?
42, doctor.
Do you drink or smoke?
No, doctor.
Had any other illnesses in the past?
Nothing other than Clostridium difficile in the recent past.
Are you taking any medication?
I am taking Cipro and Flagyl.
Are you allergic to any medicine?
No, doctor.
Any illness history of family members?
My maternal grandmother had pancreatic cancer. My father had prostate cancer, and he has heart disease and diabetes.
Well, your physical examination results are perfectly okay. Cardiology reports are regular. There is no S3, S4 or gallop. There is no murmur. Abdomen is soft. It is non-tender. There is no mass or organomegaly. Your right lower extremity is unremarkable. Peripheral pulse is good. Your left lower extremity is significant for the split-thickness skin graft closure of a large defect in the posterior thigh, which is nearly healed. Hypergranulation tissue both on your gluteal folds on the left side. There is one small area right essentially within the graft site, and there is one small area down lower on the calf area. There's an external fixation on that comes out laterally on your left thigh. The pin sites look clean. There are several multiple areas of hypergranulation tissue on the left posterior leg associated with a sense of trauma to your right posterior leg. I would recommend series of treatment with chemical cauterization of these areas till these are closed.
Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Selena Ramirez. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. What's your problem?
Well, I have a headache and pulsatile tinnitus. For the past 3 months, I've been getting severe headaches, and almost daily. I'm getting pulsations in the head with heartbeat sounds.
Exactly at which point of your head do you feel pain?
On top of my head.
Are you getting nausea or vomiting associated with the headaches?
No, doctor.
Is there any previous history of headaches?
No, doctor, but apart from last 3 months.
What's your age?
44, doctor. When I speak on the phone, I get weird sounds in my left ear. I get pulsating sounds only in left ear.
When did this problem start, actually?
Well, actually, the ear pulsations began following a flight trip to my native place.
Is there any drop or change in hearing?
No, doctor. But I had dizzy episodes in the past with nausea being imbalanced at times.
Is there any change in your vision?
No, doctor.
Well, do you smoke or drink?
I do not consume alcohol, but I used to smoke 1 pack a day, and now I have completely stopped it.
Have you had any previous illness or surgeries?
I had skin cancer on my arm and back. I am a kidney donor, so I had a left nephrectomy, C-sections, mastoidectomy, laparoscopy, and temporal arteritis.
What medications are you taking?
Tylenol, Excedrin, and a multivitamin and probiotic.
Are you allergic to any medicine?
Yes, to codeine and penicillin.
Tell me your family history of illness.
Well, my father has a cancer, hypertension, and heart disease.
Your physical examination shows your blood pressure at 120/78, pulse 64 and regular, and the temperature is 97.4. Cardiovascular test shows regular heart rate and rhythm without murmur. There is an old mastoidectomy scar on your left ear. Weber exam is midline. Grossly hearing is intact. You have pulsatile tinnitus. Left ear with eustachian tube disorder as the etiology. There's also a possibility of normal pressure hydrocephalus, deviated naval septum, dizziness, probably due to possible Meniere disease. I would recommend you to start a 2-gram less sodium diet. I am ordering a carotid ultrasound study as part of the workup and evaluation. Since your disease is related to eustachian tube, I'm prescribing Nasacort AQ nasal spray, 1 spray each nostril daily. You use the hearing protection devices at all times. I will recheck you in 3 weeks.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
All right, so real quick, Mrs. Craig is a 65-year-old female. She's 1 day post-op from a total abdominal hysterectomy. No known diagnosed allergies. Vital signs have been stable today, although we've had some pain control issues. 0.5 milligrams at the allotted. Q2 hours. Last one was at 6:30. Next one will be at 8:30. Okay. Liquid diet, orders to progress to a regular diet as tolerated, as well as starting oral meds as soon as she can tolerate a regular diet.
Has she been eating?
Not that I've seen today. No. She does have IV normal saline running, 50 milliliters per hour. Okay. SCDs are applied as per policy. She has a Foley catheter. I believe that's about it. Do you have any questions?
Okay.
Question 26. Now read the question.
Bedside shift report is so important, not only to our patients, but to our staff. It creates a transparency of communication that is shared between the two caregivers, in front of the patient and engaging with the patient and family if the patient requests. This allows for the patient to hear the information that is being shared and ask questions when those occur. It also allows us not only to confirm the goals that we have for the patient, for their healing and their recovery, but it allows us to engage with our patients and ask, what's the most important thing for you? What can I do for you today to make your day better?
Question 27. Now read the question.
You indicated that it was at a 7, and you're not due to have more pain medication until 8:30. And so what I'm going to do is I'm going to go back once I'm done greeting all my patients, and I'm going to check to see if there's anything the doctor has ordered for you that we might be able to give you in addition to the Dilaudid that you're already receiving. Many times physicians will order different kinds of pain medications that patients can take concurrently. I'm glad that you're splinting using the pillow to press down when you're coughing or sneezing. That also helps with pain control. Now, another non-pharmaceutical way to control pain, help alleviate it, is actually activity. It might seem counterintuitive, but making sure that your body is moving and that you're using your muscles actively helps control the pain. So if possible, I'd like to get you up this evening. Maybe if nothing else, just walk to the bathroom or maybe walk to the door and then back again. I think that might help.
Question 28. Now read the question.
In a perfect world, we'd rather that our patients not have to use the call light or even call us on our telephone. And one of the ways that we endeavor to do that is through hourly rounding, when either myself, a nurse, or a patient care tech will check on the patients.
Perfect. So when you press that red button, it rings at the unit desk, and someone will come on the line and ask what you might need. Does that sound like something you can do?
I can do that.
Terrific. So what I'm going to do next is update my name and number there on the board, all right?
A patient always feels better the more information they have, and we strive to do that. For example,
with our communication board. We actively update the communication board and point to it as a way for them to call us whenever they need help with something or have a question that needs to be answered.
Question 29. Now read the question.
We utilize hourly rounding and bedside shift report not only to enhance the patient experience by creating a safe environment and a healing environment for them, but it creates trust in the care team that is caring for the patient. Our eye care values integrity, compassion, accountability, respect, and excellence are mirrored in these efforts as we create an exceptional care experience for every patient and family member, I might add, every day with a spirit of warmth, friendliness, and personal pride.
Question 30. Now read the question.
We set a comfort goal for 3. What's your pain level at right now, Mrs. Craig? On a scale of 0 to 10, how do you feel?
About a 7.
About a 7. Okay. She's on a liquid diet.
Is she taking anything for the pain?
She is. She has ordered 0.5 milligrams of Dilaudid IV as needed every 2 hours. And she did receive that about 6:30. I updated the board, so the next one due, Mrs. Craig, would be about 8:30 this evening. She's also been using splinting, which has helped with the abdominal pain. She's on a clear liquid diet with orders to progress to a regular diet as tolerated.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer, A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Questions 31 to 36. You hear the lecture given by a senior surgeon on the role of diabetes in the end-stage renal disease. You have 90 seconds to read questions 31 to 36. Role of diabetes in the end-stage renal disease. Of late, diabetes has become the primary cause of end-stage renal disease worldwide. This is due to the fact that diabetes, especially diabetes type 2, is increasing. Approximately 45% of new patients receiving dialysis in the U.S. are diabetic. Early diagnosis of diabetes and early intervention are crucial to prevent the progression towards renal failure, seen in a significant percentage of type 2 diabetic patients and in many type 1 diabetics. The presence of microalbuminuria is the early clinical evidence of diabetic neuropathy, defined as the appearance of low but abnormal levels of albumin in the urine. The characteristics of diabetic neuropathy are a decline in glomerular filtration ratio, progressive increase in proteinuria, hypertension, and a high risk of cardiovascular morbidity. Therefore, the evidence of microalbuminuria should trigger diagnosis for possible vascular diseases and aggressive intervention to cope with all cardiovascular risk factors in diabetics type 1 and 2. The natural history of diabetic neuropathy progresses slowly over the years. In type 1 diabetes, microalbuminuria occurs after 5 years, and the end-stage renal disease develops in 50% of type 1 diabetics. Whereas type 2 diabetics has a more variable course. Very few patients with microalbuminuria progress to advanced renal disease. Without intervention, approximately 20% of patients of type 2 diabetes develop an end-stage renal disease. However, due to the increased number of type 2 diabetes patients compared to type 1 diabetes, the maximum number of patients on dialysis are type 2 diabetics. There are many factors which account for the pathophysiological of diabetic neuropathy. Primarily anatomical and structure changes in the kidney result in increased glomerular capillary pressure in diabetes, which is associated with hyperfiltration at the glomerulus. The next factor is the glucose that can increase the formation of advanced glycosylation end products by inversely binding to proteins in kidneys and circulation. Over the years, these formed advanced glycosylation end products, which stimulate the growth in fibrotic factors, contributing to overall renal damage. Thirdly, angiotensin II contributes to the advancement of diabetic neuropathy by narrowing the efferent arteriole in the glomerulus, subsequently resulting in higher glomerular capillary pressures. While diagnosing diabetic neuropathy, early investigation of glucose intolerance in diabetes to distinguish patients who are at risk for developing microalbuminuria is suggested, especially if they have other risks for type 2 diabetes, such as lipid central obesity, abnormalities, or hypertension. Therefore, the investigation of microalbuminuria presence should be performed at diagnosis in patients with type 2 diabetes, whereas in patients with type 1 diabetes, since microalbuminuria rarely occurs with short-term type 1 diabetes, the diagnosis should begin after 5 years of disease. According to the findings, the microvascular complications develop during the pre-pubertal period of diabetes. Therefore, clinical judgment should be demonstrated when individualizing these suggestions. The object of diabetic neuropathy therapy involves multi-clinical approaches. Tight glycemic control is the keystone in the prevention and management of diabetic neuropathy. The United Kingdom Prospective Diabetes Study and Diabetes Control and Complications Trial have established that an intensive diabetes therapy can considerably decrease the risk of microalbuminuria and neuropathy development. Nonetheless, blood pressure control is another keystone in prevention and treatment, in addition to glycemic control. The significance of blood pressure control, irrespective of what agent is used, cannot be emphasized enough in diabetes, both for slow progression of neuropathy and for preventing cardiovascular morbidity. According to the recent Joint National Committee guidelines, blood pressure in diabetics is reduced to less than 130/80 mmHg. It is very crucial for doctors and patients to understand early on the 3 or more agents. Angiotensin receptor blockers or angiotensin converting enzyme inhibitors are considered first-line agents in patients with concomitant hypertension and diabetes. Diuretics might be added as a second-line agent in many cases after angiotensin blockade in diabetes. Dihydropyridines, a class of calcium channel blockers, may be considered as the third or fourth-line agents in diabetics, only after initiation of angiotensin blockade and diuretics. There are also other non-pharmaceutical suggestions, such as dietary restriction of protein intake, restrictions of protein to 0.8 grams per kilogram weight per day in patients with overt neuropathy, or even 0.6 grams per kilogram weight per day is recommended in the case of declining glomerular filtration ratio. Moreover, it is very essential to stick to a low-sodium diet in diabetic neuropathy, since many diabetics with renal disease are salt-sensitive. Therefore, restricting salt intake will certainly help in reaching blood pressure goals, with secondary benefits of regression of left ventricle hypertrophy, decreased stroke risk, and reduction in proteinuria. A recommended low-sodium diet of 2.3 grams daily in patients with diabetes and either hypertension or proteinuria. Moreover, avoiding nephrotoxin agents, such as radiocontrast media, nonsteroidal anti-inflammatory drugs, is highly recommended. Last but not least, annual diagnosis of microalbuminuria in diabetics will allow the detection of neuropathy at an early stage. Improved glycemic control and intensive anti-hypertensive treatment will ultimately slow down the progression of diabetic neuropathy.
Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
The samples of tissue cells can be taken from almost any parts of the body, depending on the type of tumor and its location. The method of taking samples is determined. For instance, the methods followed for brain biopsies is entirely different for skin biopsies. Certain types of biopsies involve the removal of an entire organ, which are only performed by surgeons. However, other types of biopsies remove tumor samples using a thin needle or through an endoscope. In this session, I am going to explain the most common types of biopsies used in cancer diagnosis. Needle biopsy. Fine needle biopsy or fine needle aspiration and core needle biopsy or core aspiration are the two types of needle biopsies. Fine needle aspiration is performed using a thin, hollow needle affixed to a syringe to pull out small pieces of tissue and a small amount of fluid from the tumor. In case the tumor is deep inside the body and cannot be felt, then the needle can be guided while watching on an imaging tool such as an ultrasound or CT scan. The main advantages of fine needle aspiration are that there is no need to cut the skin, and in some cases, the diagnosis is made on the same day. However, the disadvantage is that sometimes it becomes impossible to remove enough tissue for a detailed diagnosis. Although fine needle aspiration is a type of biopsy, it is also classified as a cytology test. However, in a core biopsy, the needles are slightly larger than those used in fine needle aspiration. In a core biopsy, a small cylinder of tissue is removed. At times, special vacuum tools are used to get larger core biopsies from breast tissue. However, diagnosing core biopsy samples take longer than fine needle aspiration biopsies. Therefore, the results also take longer. Excisional or incisional biopsy. In this type of biopsy, the surgeon cuts through the skin to remove the complete tumor, called an excisional biopsy, or a part of a large tumor called an incisional biopsy. In an endoscopic biopsy is a flexible, thin, lighted tube with a lens or a video camera affixed at the end, allowing the physician to look into the internal parts of the body. Tissue samples are also taken out through the endoscopic biopsy. Different types of endoscopes are used to look at specific parts of the body. For instance, one kind of endoscopy is used to look at the inside of the throat, sinuses, and nose. Laparoscopic, thoracoscopic, and mediastinoscopy. Although laparoscopy is much like endoscopy, it uses a laparoscope to look inside the abdomen and remove tissue samples. Similar procedures are followed to look inside the chest. These are called thoracoscopy and mediastinoscopy. Laparotomy and thoracotomy. Laparotomy is a kind of surgery where a vertical cut is made from upper to lower abdomen to remove samples. This may be performed when the suspected area could not be diagnosed with other simpler tests. There are many ways to perform a biopsy. The skin based on the type of suspected skin tumor. Shave biopsies remove the outer layers of the skin for certain basal cell or squamous cell skin cancers. However, they aren't used for the suspected melanomas of the skin. As discussed earlier, punch biopsies or excisional biopsies are used to remove deeper skin layers and are diagnosed how deeply a melanoma has gone into the skin. Sentinel lymph node mapping and biopsy helps the surgeon to know which lymph nodes to remove for biopsy. Sentinel node mapping and biopsy is a common way to diagnose whether a cancer such as melanoma or breast cancer has spread to the lymph nodes. This can detect the lymph nodes that drain lymph fluid from where the cancer originated. If the cancer has metastasized, these lymph nodes are usually the primary parts to affect.
That is the end of Part C. You now have 2 minutes to check your answers.